Just like that, we're back. Listen, I knew when they got a colorectal surgeon and a GI doctor together, it was going to be problems. They always think it's always drama, always drama.
All
All right,
right.
so let's just dive back in because I know we've
Okay.
been having some technical difficulties. Let me tell you something. So we've we've crossed paths a few times.
Yeah.
I think shared a few patients a few times, and it was funny as I was starting this series, and I've been getting, the finger wag from my social media team, like, hey, you got to get more on social media. I do this. So
Yeah.
I got a couple of, followers here and there, whatnot. And, so when we created this, the Love Below series, I was like, all right, I got to get me some heavy hitters. So I'm going to be honest with our audiences. I went to AI and I literally put in there, I said, hey, who are the top GI doctors on social media right now? And across the country, Dr. Earl Campbell came up as number 4 in the entire country for popular GI doctors on social media. And he's right down the street, and I had his phone number, so of course, had to get him on. And Dr. Erin King-Mullins, Dr. Tushy Touchup, joined by Dr. Earl Campbell, the illustrious. So Dr. Campbell, tell us
Yes.
what's the difference between gastroenterology and colorectal surgery? And don't be shy.
Okay. So, I guess, but then you don't want to also speak for your profession, but I'll speak based on what I know, what I can say. So, gastroenterologists, we perform endoscopic procedures or natural orifice procedures. So, anything we're doing, we either going the digestive tract, there's an opening and an exit, right? Either we're going in through the mouth or we're going in from the bottom. Oh, so I said opening the exit, not to offend anyone, if it's the entrance for some individuals, whatever. There's 2 openings. We do procedures from above or below. That's it. Colorectal surgeons, they may do procedures sometimes through a natural orifice. They're going to be going through the rectum, but they may also sometimes actually open up someone's abdomen or place ports into someone's abdomen and do something minimally invasively. And then even sometimes now over the more recent years, doing robotic surgeries. So ours are done, gastroenterologists do procedures with fiber optic scopes, whereas the colorectal surgeons are doing more open or laparoscopic procedures. And in terms of things that where the overlap, one of the biggest things, this is Colorectal Cancer Awareness Month. So we're talking about colorectal cancer. And so the majority of colonoscopies done in the country are done by gastroenterologists. So we do screening colonoscopies. Colorectal surgeons do colonoscopies as well. Now, if I were to do a colonoscopy and I come across a polyp or cancer in the colon, if it's something that can be removed endoscopically, meaning done through the fiber optic scope, I will remove it at the time of the procedure. In fact, because I'm an advanced interventional endoscopist, a lot of my colleagues that are general gastroenterologists, they will send patients to me that have had large polyps for me to take them out. Now, if it is something that is too large or involved in the wall of the colon to get removed endoscopically, then I would send it to one of my colorectal surgery colleagues to have that patient get surgery to have that segment of the colon removed. And we work hand in hand. If I see a polyp or a mass and it can't be removed endoscopically, then I'll place a tattoo next to the lesion so that, like Dr. Erin King-Mullins here will then go and do the surgery. She can see where the tattoo is, know where to cut, and then remove that segment of the colon. So.
Yeah, that's a great summary. I think the biggest thing is, we meet somewhere in the middle, right? Gastroenterologists. So Dr. Campbell is an advanced endoscopist, so he does a lot of high level procedures. But in general, gastroenterologists, some of them may have different fortes, right? So
Right.
some of them may be hepatology, they're treating
Right.
liver disease. Some of them maybe transplant hepatologists. So they're managing patients who've had a liver transplant before, working them up for that. Peptic ulcer disease. So people have ulcers, reflux. Your favorite. Irritable bowel syndrome. But I'm on okay. But pancreatitis. Various other things.
Right.
Whereas colorectal surgeons we tend to do now. We do some basic medical management, right? Patients show up to see me for incontinence. They see me for diarrhea, constipation, and those things. And I can do the initial kind of basic workup and all of those types of things. And then understand once it gets beyond my level of basics, I may say, hey, you need to go see my friend, Dr. Campbell, or his office, at least, since he's the advanced endoscopist. You may have other staff or colleagues in the office that may do some of the more medical management. So one of the things, again, kind of touching on this Love Below series and thinking about women in particular, because, we are complex beings, and not only just because of emotional things sometimes, and please don't take that the wrong way, but in general, we have a different anatomy, right? There are with the female gynecologic tract with ovaries and things like that. There are different times where different hormonal levels may change, not only on a monthly basis, but also as we age. And there are some natural changes that happen within the GI system there. And again, I know you're an advanced endoscopist, but tell me a little bit about, a woman comes to see you with some specific gastrointestinal issues. How might you see or evaluate her differently than, say a man?
One of the biggest things that I would think about or keep in mind that I feel like not everyone always thinks about, and it's actually a case I diagnosed a patient with this in when I think I was an internal medicine resident, maybe a med student, is I always think also about endometriosis. So the women that come in and they have abdominal pain, particularly sometimes they'll mention they feel this nodule, right? They may feel a nodule on their abdominal wall, and they'll notice that it comes and goes, right? And one of the interesting things is they may not even have thought about it until you mention it. And I'll always ask, one of the big things I'll always ask with any of these symptoms, is it cyclical? Does it kind of follow your cycle? And they may notice, I notice a nodule, it comes, and then when my period comes, then I notice that it kind of just disappears or it may shrink away. And basically, for those that may not know, endometriosis is basically tissue from the uterine lining that basically can deposit anywhere in the body. And even though it is not within the uterus, it still behaves as if it was in the uterus in response to the hormones that fluctuate throughout a woman's menstrual cycle. So the tissue will hypertrophy, get larger, and then it'll shed, and it can cause pain, and that's why it'll change in size throughout the cycle. So that's something that I always keep in mind. Especially, I have a lot of friends, family members. So this is a side. Another thing also too is so GYN, right, will also tie in very closely with the GI tract, right? Down when you get to the pelvis, there's not a lot of space down there, right? In the abdomen, there's a lot of space. As you get further down towards in men, the penis, in women, the vagina, and then in men or anyone, the rectal area, there's not that much space. So any inflammation, change in the areas can affect the organ system. So also we'll always think about fibroids as well,
Yep.
And I've been seeing fibroids, sharing friends, family members, and I've seen it so much, just hearing about it, friends that call me just for advice, that have had to undergo surgery for it. But I've seen it to the point where I've been wondering, I was like, what is going on? I feel like I have so many friends and colleagues that are Black women that have been suffering from fibroids. So I always think about also fibroids as well as endometriosis. But
So
I think
thanks for pointing that out. Yeah, thanks for pointing out, because listen, our friend and colleague, Dr. Sohini Hawkins, was our very first guest in this series, and we talked just about that, fibroids and endometriosis. So thank you for just kind of reiterating that in that discussion, right? Because, I feel like, and women oftentimes, to be honest, feel like they're being gaslit, right? For if their physicians are not truly informed about the impacts of fibroids and endometriosis and the current rates of that, and how it can impact the gastrointestinal tract. And because it has to be something that has to be considered and diagnostically specifically evaluated via an ultrasound, an MRI, or someone that's informed that knows to look for that. And if someone just doesn't, if there's a physician or a provider that doesn't cross their mind, a lot of times it is passed along to the woman as just secondary to their cycle. And while it might be secondary to their cycle, it does not mean that it's not pathologic. It doesn't mean that it's not a problem that needs to be treated. So thanks for sharing that.
And one other thing too, I don't know if you all discussed that, but another thing I keep in mind is, and I'm not well versed on this, but pelvic congestion syndrome. That's something too that I always kind of in the differential as well when I'm seeing, what is something potentially that a woman can have when she's having pain in that area that I got to keep on the list that you will not have in a male patient, of course.
Okay, so sorry, I know this is corny, but I gotta do this again because our second guest was a pelvic floor physical therapist.
Oh, so nice.
Dr. Jennifer McGowan. So we definitely talked about that, especially patients who have had radiation treatment in the past or different complex birthing histories that they can have different causes for their pain, which again may not necessarily ring the traditional radars that we have in medicine, but that does not, that doesn't minimize the impact that it has on the functionality and the pain in the day-to-day lives of these women. So thank you for being informed about that. And so I know you'll probably get a couple of extra likes and follows and probably some new patients, some female patients out of that, because they're like, yeah, somebody's actually going to listen to me. So definitely appreciate that. So listen, all right, so for those who are just joining us, Dr. Erin King-Mullins, also known as Dr. Tushy Touchup, we're talking to Dr. Earl Campbell, number 4 most popular social media gastroenterologist in the country, who's here in Metro Atlanta. And we're going through a few things tonight. So it's Colorectal Cancer Awareness Month. Screening age is 45 or even younger if you have a family history or some risk factors. So please make sure that you are talking to friends and family and physicians and all of those folks to understand what your risk is, to know when you need to get checked. So, there's a couple of things that we also want to get to tonight, and we'll keep circling back to this colorectal cancer awareness month because it's so popular. A lot of people ask me what I think is the reason and the cause for this younger age at diagnosis. And let me just ask you, what's your opinion on these younger diagnosis of colorectal cancer?
We don't have a definitive answer on that yet, but I think like one of my gut feelings is I think a lot of it is environmental. The increasing use of processed foods. I think though that's probably one of the biggest things, honestly. Now we're in a society where things are moving towards, we want to have things right now, faster. And I'll never forget when I first saw the advertisement for, it was like bacon in a box that is just on the shelf in the grocery store. It's not even in the refrigerator section. I was like, this in and of itself is concerning because what is keeping this meat preserved? And one of the things that we know is a carcinogen is sodium nitrate, which is a preservative in a lot of these processed foods, cured meats. So, hot dogs, bacon. I always tell patients, if they're, just trying to decrease the risk, to look for the uncured meat. So you see hot dogs, it'll say uncured. If you flip over any of those, the bacon, hot dog, that last ingredient, you're going to see sodium nitrate. That's a preservative. So I tell patients, they now, as people are becoming more aware of it, you'll look and they'll advertise it as, oh, this is the uncured. And I tell patients, it's not going to last as long as a fridge, but it's going to, slightly decrease your risk if you were to choose that option as well. So.
Yeah, that's a good point. And, one of the things to kind of piggyback on what you were just saying about environmental, it's not only, I tell people it's kind of what you do eat and what you don't eat, right? And so it's that processed food, that prepackaged things, you want to eat on the periphery when you're shopping in the grocery store, you want to shop on the periphery. But what are you not consuming? If you're not consuming a mostly plant-based diet or a more whole foods, high fiber diet. So it's a little bit of a combination of the two. So, you just have to make sure you're having that variety. So tell folks, for those who may, have some people are really naive to what a colonoscopy is in the process. They just know that colonoscopies are used to detect colon cancer or polyps and things like this. Tell us a little bit about the process of, what you go through to get a colonoscopy and what are the findings? Like, what are we really looking for and what does it mean? What can we do with that information?
Yeah, so pretty much you're laying there. You don't even need anesthesia. The tube is about this big. We just place up the rectum.
That tube is not that big. Why are you even doing
that?
No,
I'm joking. So, all right. So, okay. All right.
How big is the tube? How big is it?
It's about this big, and then about 10 to 12, 10 to 11, I'd say, like millimeters in diameter. So it's not low.
Okay, so it might be the size of my thumb, but listen, I tell people the tube is smaller than most of your poops.
This is true. So for the colonoscopy, also, I'll tell you, you're completely asleep for the procedure. Some places may still use what's called like conscious sedation. That means fentanyl versus most places now we use propofol. All right. So you're completely asleep for the procedure. You're laying on your left side. There's a flexible, keep things flexible. Years ago, they used to have rigid scopes. There's a flexible fiber optic scope that's placed to the rectum and has lights on the end of it and a camera, and we're able to look throughout the colon. And we're looking not only for cancer, but we're looking for precancerous lesions like polyps so that we can cut them out, remove them, to prevent them from turning into cancer. That's an even better scenario. We're going to see it and we can stop things before we even get to the point of cancer.
Keyword prevention, right? So
exactly.
An ounce of prevention is worth a pound of cure. And, a lot of folks will ask us, I don't want to have that procedure. I don't want to do the poop. I don't want something up my butt or whatever, blah, blah, blah. And so just like you said, prevention. So I ask people because they're like, oh, what about the poop test? What about a blood test? I'm like, would you rather something tell you have cancer or would you rather something that can help prevent cancer? So that's one way to kind of frame it when we're talking to folks because it's
and I want to touch on that too, actually.
Go ahead.
So, and speaking so I deal with that, my family's from Jamaica, so trust me, you see it's an even bigger thing about people not wanting to go through those things, especially in West Indian culture, and I don't want anything up there, but it's very important for this to get done. So, right, recently was just approved. I won't touch on it today because that's a whole other thing that's still early phase. There was a blood test that was approved, but it's not, I don't know if it's on the market available yet, or even insurance companies even have methods yet of whether they're going to cover, et cetera. But for colon cancer screening, like you mentioned, there is a stool test. So there is a fecal occult blood test, which is a stool test that just looks for microscopic blood in the stool, so small bits of blood in the stool. And then there is also, more commonly what we see now on these commercials, Cologuard, or a FIT DNA test. So that test has two components to it. The FIT is a fecal immunohistochemical test, which is looking for blood in the stool. And the DNA component is looking for abnormal DNA that's being shed into the stool. So positive FIT DNA means you have one of those things that's triggering the test positive. It doesn't tell you which one. It's going to be a positive or negative. Now, the FIT DNA test, or Cologuard, is actually very good at detecting colon cancer. But here's the thing I always tell my patients. Do you want to wait until it gets to the point where it's cancer? It's not as good at detecting precancerous lesions like polyps. So it's good at cancer, but the biggest thing is with colonoscopies is you're able to catch these when they're before they turn to cancer, so that we can remove them. And then the other benefit, like I always tell patients, Cologuard is approved basically for if it is negative. If it's negative, then you get a repeat colonoscopy in a repeat stool test in 3 years. Whereas if you have no family history, no polyps, and your colonoscopy is clear, you don't have to do screening for another 10 years. Right, so that's the colonoscopy is going to buy you the longest interval in between screening. So that's the big thing I always tell patients to keep in mind. And then also, if the stool test is positive, then you got to get a colonoscopy. The stool test will only give you, like I said, positive or negative. The colonoscopy will also allow you to actually see what is the cause and to, like I said, remove something in a